Mary Helen Taylor, woman in the driver's seat. Today, we are here at the University of Toledo Medical Center meeting two incredible physicians of the all-female breast oncology team, Dr. Rizk and Dr. Hadzi. Please, let's go inside and meet these amazing women. Welcome, doctors. Thank you so much for being here. I understand you have a very incredible distinction, and could you share what that is?
Sure. Thank you so much, Mary Helen. Yes, we are the only all-female breast cancer team in the region. We're so lucky to have recruited Dr. Natalie Rizk to our institution, and we're very excited about the future of breast cancer care at UTMC for the women of Northwest Ohio.
Absolutely wonderful. What inspired each of you to pursue a career in breast oncology, and what has been the most rewarding aspects of your work?
So for me, it's actually a bit personal. I've lost both my parents to cancer. I lost my dad. I was a third-year medical student, and as a third-year surgical resident, my mother was diagnosed with stage 4 cholangiocarcinoma. So it was prior to losing my mother's diagnosis and her subsequent passing from cancer, I wanted to do trauma critical care. So for me, after my mother's passing, I decided that I wanted to pursue something in the oncology world. So in breast cancer, I think if you look at the outcome for breast cancer, the survivorship percentage is quite high.
Yeah, Exhibit A.
Right. So a lot of patients do well, and I think that's really owing to screening and early detection.
Wonderful.
So
And for me, I actually didn't go into medical school thinking I would do oncology, but I fell in love with the subject matter during my second year of medical school and was entirely sure I wanted to do something oncology related. There are kind of three different flavors of oncology: surgical oncology, medical oncology, and radiation oncology. And radiation oncology, I think, fit my interests the best, both for scientific interest and humanism. Kind of married the two of those the best for me. But I love oncology, love the people, the patient population, but also the people who work with patients with cancer. I think they're a special breed,
They certainly are.
and it's just such an honor and privilege to work with people like that every day.
Wonderful. What recent advancements in breast surgery and treatment are you most excited about, and how do they impact patient outcomes?
I think the biggest thing is, especially in the world of surgery, is we're seeing a de-escalation of surgical interventions, meaning that historically, when a woman went into the operating room, she didn't know if she was going to wake up and have, what's called an axillary lymph node dissection or just sampling of her lymph nodes. But we have moved to the point where now we're rarely ever doing axillary lymph node dissections. So I think what's really exciting, as a surgeon, I love operating, but we are definitely seeing a de-escalation of surgical interventions based on especially the world of radiation. So we know with the axillary lymph node dissections, women are left with a lot of morbid subsequent side effects of removing all the lymph nodes, specifically lymphedema, limited shoulder mobility, pain. But there were two big trials one was completed here in the US and one was completed in Europe that demonstrated with adding radiation to the field is comparable to removing all the lymph nodes, and even better because you don't have the same side effects
That's amazing.
So I think that's really exciting. And of course, the world of chemotherapy. I think what's really exciting is I have patients who were diagnosed with stage 4 breast cancer who are alive 6, 7, 8, 9. I think the longest I have one is 9 years because of all the advancements we've made with the chemotherapy regimens that are given. So,
Wonderful.
Yeah, absolutely. In the same vein, on the radiation front, we have also demonstrated through, high quality trials that, more is not always better. More is sometimes just more, and actually more can sometimes do harm. And the first principle of medicine is to do no harm. And that has been really exciting for me to see, how things have changed, or evolved, rather, since my training, where, say, postoperative radiation course used to be 5-6 weeks, and now we do as few as 5 treatments. So 5-6 weeks is 25 to 30 or 33 treatments. Now we do as few as 5 treatments, or more commonly just 15 treatments. The outcomes are not in any way inferior, and it's better for women. There's less long-term toxicity, and also, who are the women we treat? Their mothers, their wives, their daughters, sisters. They have a million other things to do on their plate. So just freeing up weeks of time for women also improves access to care that they need, because radiation lowers somebody's risk of cancer occurrence by a good 70%. Some women are not able to receive the long treatment because of all of these other hats they wear. They're the default person for everybody in their life. So to now be able to confidently offer them a shorter course and be confident that their outcomes will not be inferior, and them able to complete the shorter course, is really gratifying. So that has been a really exciting advance in our field, and also the advance in our hardware. Our linear accelerators are better, faster, more sophisticated than before, and we can do heart-sparing radiation, lung-sparing radiation, limiting stray dose to all the adjacent normal tissues. So it's very high-quality radiation therapy.
Yeah, it's very exciting. What advice would you give women to be proactive about their breast health, and how can early detection save lives?
I think the biggest thing the data really speaks to is screening, screening, and screening. As far as the guidelines are concerned, especially, I think the biggest thing for me is we're definitely seeing cancer in younger and younger women, is assessing a woman's lifetime risk for cancer and acting accordingly. So if you are considered high risk, the recommendation is that you are screened earlier. So screening is probably the biggest thing. The other thing is lifestyle, and I think that's something that, I think we live in a culture where we're reactive, where we really want to be more proactive in helping decrease our risk. And when I say lifestyle, I think we know that obesity increases a woman's lifetime risk. We know that excessive alcohol consumption increases a woman's lifetime risk. Smoking increases a woman's lifetime risk. So these are all modifiable risk factors that, educating the patients about. And often when I speak to patients, they'll say to me, oh, well, I did not know that. Well, I didn't know that. So that's what I would probably say is really important. Screening and, lifestyle modifications.
Absolutely, I echo all of that. I think women tend to sometimes trivialize, and put themselves on the back burner, because you're, again, everybody's default person. And I would advise, knowing what your body feels like, knowing what was not there a month before and now there is maybe something you palpate. You should not trivialize that, and you should promptly bring it to the attention of a medical professional. Early detection is everything. I mean, the earlier we diagnose cancer, the better your outcomes, the better your prognosis, and the less treatment you need. I think that's, one thing that is not very apparent to people. But the earlier you diagnose a cancer, you'll need a far less treatment, and you'll be back to living your regular life sooner.
And breast cancer is a deeply personal experience for many of your patients. How do you approach providing emotional support while delivering medical care?
I would say just by listening. I think often physicians lose we look at the diagnosis, but I look at the whole patient. Like, it's not just the breast cancer. This is a mother, this is a sister, a daughter, a professional who has a life. And so that diagnosis is not everything. So I listen, and sometimes there are things you can't help with that are not related to the breast cancer, but you just listen to them. So, yeah.
Absolutely. I think, the way I show up to every consultation is knowing that, being aware that this is probably the patient that I'm about to meet. This is one of the worst days of their lives. It may be just another Wednesday for me, but for them, it's one of the worst days of their lives. And I'm very intentional about how I show up, and I want them to see that I'm an ally and I want what is best for them to not just survive, but also thrive as a survivor. And what Dr. Rizk said, highlighted the importance of holistically looking at the patient. In radiation oncology, we have the advantage of really getting to know our patients because we meet them once a week. So you develop a relationship, you get to know people through the several weeks they're under your care, and you help kind of nurture that relationship, doctor-patient relationship with an allyship that is, I think, very therapeutic. It's a therapeutic alliance, and I think it shapes the entire experience of having cancer for the patient. And I'm proud to highlight that our staff does a wonderful job of curating this experience for the patients, and they feel well taken care of. They receive compassionate care at every human touch point, from check-in to check-out, and we take great pride in that.
Oh, truly is a team.
Do you mind if I add something
Oh,
else
of
to that?
course not.
Sure. And so I think the other thing is accessibility, like the patient's ability to access the physician. Like all my patients have my cell number.
That's incredible.
And the majority of them are very respectful, quite respectful. But I think that's one thing that I often found earlier on was when my patients couldn't get a hold of me. And then when they were able to get a hold of me, it was frustrating for me that it wasn't quick enough. So I made it a point to put my cell number on my business card.
This is absolutely incredible.
So accessibility is important. Yeah.
Wow, amazing. As women leading in your field, what changes would you like to see in breast cancer treatment and awareness in the next decade?
I mentioned earlier that we're seeing breast cancer in younger and younger women, and it's actually really scary. There was just a report that came out in Lancet, and definitely we're seeing it. And the question is why? These women do not have genetic mutations. I lost my youngest patient last year who was 26 years old to metastatic HER2 positive breast cancer, no genetic mutation. So one area of, I think what I'd like to see more is look deeper into that. Is there something, is it environmental? Is it something that is within our homes? Is there something, within the food that we're taking in that is increasing this risk in young women? So that is one area of research that I'm really interested in. Because we do know there are a lot of chemical carcinogens that are not regulated by the EPA.
As a survivor with 3 daughters, I thank you for saying that. I graduated a drug-free, alcohol-free virgin athlete, never picked up a cigarette, a foreign substance. And, a person with my daughter Maria hadn't had a dream, I never would have gotten checked at age 42. So you just wonder.
Yeah.
It certainly wasn't lifestyle for me
right.
personally, but I know that can be a factor. But I do think there's you just wonder what is going on, and hopefully.
And I think it's an area that needs more research.
Yes, absolutely.
So.
Absolutely, I completely agree. I think it's a really an enigma in this, not just for in young women with breast cancer, but also just young people in general, young adults. Big head scratcher. We don't know why young adults, stage 4 colon cancer, for example, is on the rising incidence in young adult Americans, and it's very aggressive, deadly, and we have not figured it out. All the leading journals say by 2030. Colon cancer will be the #1 cancer killer of young Americans, and we still don't know why.
Oh.
So I think raising awareness, figuring, why, there has to be an explanation as to why we need to have a kind of multi-pronged approach to answer that very important question. And then as far as other advancements, I think, personalized oncology, personalized treatments, one size does not fit all. Medical oncology has already moved in that direction. We used to kind of lump all breast cancer like as one, but now we know there's so many different flavors of breast cancer and we have personalized care. Our field still lags behind somewhat in that. I think, this century is where we're going to move the needle in that direction, so that we can intensify or de-intensify treatment depending on what like the genetic underpinning or the epigenetic underpinning of your cancer tells us. So that'll be, really great to kind of find that Goldilocks fit for every woman. And hopefully we will be able to de-intensify therapy without impacting adversely the outcomes. We want to focus on, something known as therapeutic index or therapeutic ratio, where you want to deliver highly effective treatment, but that is minimally toxic. And figuring that out, we still have some ways to go.
Yes.
So that's something to work toward and look forward to.
Well, I cannot thank you both enough for being with us today and all that you do to impact women on this journey that they never wanted to be on, but it's so amazing that here at UTMC we have women empowered by your work and by your care. And thank you again.
Thank you for having us. Yeah, absolutely.
Thank you very much for the honor of the podium.
Yeah.
Thank you.
Thank you, Dr. Rizk and Dr. Hadzi, for sharing your compassion and knowledge and for helping women going through the breast cancer journey. Let's hop down the road and see who's next in the driver's seat.